Welcome back to the P3 podcast. As always, I'm your host, Utilise. I do know it's been a hot minute since our last episode, and that is because things have been absolutely mental behind the scenes, getting our new monthly subscription athletic footwear for health professionals up and running. Now, I'm not going to do a deep dive into the ins and outs of that subscription today, but if you do want to find out more about this monthly CPD subscription, head to progressivepodiatryproject.com/AFHP. Acronym for Athletic Footwear for Health Professionals. Now, what we're going to be discussing in today's episode is we're circling back around and going to be exploring some more exercise dosage parameters, because this is one area that clinicians often seem to have one of the most difficulties with when it comes to that confidence when it comes to exercise prescription. Clinicians can often be quite good at identifying what may be the most appropriate exercise for the patient or client, but then they trip up and they start to be plagued with a little bit of uncertainty when it comes to, well, what's the actual dose that I should be prescribing at? And the answer varies greatly from person to person because everyone's starting tolerance will be different. The goal activities and the goal performance or tissue responses that we're after, they will also vary as well. So today we're going to be having a look at an option that we can utilize outside of sets and repetitions, and that is AMRAP for time, as many reps as possible for time. So let's get into it. The Progressive Podiatry Project, here to share knowledge, insights and information for you to improve your clinical practice and, most importantly, help you help your clients. Okay, so AMRAP for time, as many reps as possible for time. So essentially what happens with this exposure is, if anyone's ever stepped foot into a CrossFit torture box or gym, it's a torture box, let's be real. If you've ever done a CrossFit workout or any of those circuit-based workouts, you would likely be familiar with AMRAP. So essentially it's performing as many repetitions of a given movement in a set period of time. Now, this is often where strength meets conditioning in the gym setting. Now, does prescribing this type of CrossFit AMRAP work for rehab patients, especially in the early stages? Definitely not. But we can draw on this principle to help our clients navigate their rehabilitation when we're dealing with either patients that are a little bit fearful when it comes to movement, or we may be dealing with a tissue that might be in the early stages of healing, or it might be quite reactive. So AMRAP in this sense, when we're using it in rehabilitation mode, is slightly different, but the clinical utility is very high and it's very beneficial because it can help our clients keep moving and keep up with the regular load exposure that we need, especially in those early stages of rehabilitation, to help almost fast track the recovery process. Now, how can it fast track the process? Good question. So one of the clinical examples that will happen, let's say we've prescribed someone, I always pick on this, 3 sets of 10 repetitions, but let's mix it up. Let's say 3 sets of 20 repetitions for a prescribed movement. Now, that may have overdosed someone. So they go, okay, Talisha's given me 3 sets of 20, so I'm going to do it. They may have made it through the first set of 20, and that's fine. Then the second set, it might have started to get grumbly, say, I don't know, the 10th repetition. And then by the third set, they may only be able to do 2 or 3 repetitions because we've overdosed them. And then what happens is they're at home doing those exercises. Then they've gone, oh, this is really sore. They may be sore the next day. Then they don't have an appointment scheduled with us for 2 weeks, and they don't contact us to let us know that it's flared. They come back in 2 weeks later, oh, I did the exercises once, but it made it worse, so I stopped doing it. Now, this is the situation that we don't want because, again, we can sort of be perpetuating this. It's almost a bit of a boom-bust cycle, just in a very small scale, because they may have overdosed and then, okay, we're going to overdose the rest in response to this. The better way that we approach rehabilitation for tissue adaptation, and for especially those sort of pathologies of chronicity, we tend to need higher frequency, lower dose movement, especially in the early stages, to help point the body in the right direction for that optimal loading. So this is where AMRAP for time comes into it. So again, like an example, if you're not familiar with AMRAP for time in CrossFit or gym settings, so it might be an exercise circuit. So we may have squats and then box jumps and then overhead presses. So it may be for 1 minute you'll do as many squats as you can, and then once the buzzer goes off, you move to the next exercise. So you'll do as many box jumps as you can in that minute, and then as many overhead presses in that minute or the following minute. Now, this isn't what we want to do oftentimes in a rehab setting, but that's essentially what this is built off. So AMRAP in rehab, essentially we may select one exercise or a group of exercises. It's typically one exercise. The AMRAP for time, so it's as many repetitions as possible within that time parameter. And then the reason we're giving this time parameter is it's just something quantitative to formulate our dose, and then we couple this with education around the level of acceptable discomfort or pain during this time. So I will explain how I explain this to patients, but before we get to that, when we look at, we're going to just have a little bit of a discussion about the spectrum that or the journey that we take when we go from rehabilitation mode to performance mode. So people, it is a spectrum. We don't go from rehab mode, flick a switch, and then we're into performance mode. There's often a bit of a transition. So typically, when we're seeing patients, we've got rehab mode. So rehab mode is when we tend to be a little bit more prescriptive with either the type of exercise or the dosage of exercise. And then we may move into maintenance mode. So for a lot of people with maintenance mode, this might be where the journey with us ends, because they've returned to just their usual daily activities that they want to do. So it might be walking the dog in the morning, it might be their park runs on the weekend. So it's where they're needing to function and do what they want to do, but it might not be a specific performance goal that we're after. So some people, we may have them for a bit longer or refer them on to another health professional or fitness expert to take them into the performance realm. So this might be a runner recovering from an injury, but it's not just running a distance that they're looking to get back to. It might be running a certain distance at a specific time. So we may need to get very specific with our movement prescription at that point. So it kind of follows, can be a little bit prescriptive, then we get really general, and then into performance mode it can be general, so we've got our base level of fitness, and then we get prescriptive again. So it's almost like a diamond that you can picture it with. So when we're in rehab mode, again, rehab mode can be early stages of tissue healing, whether or not it's post-injury or post-surgery, because surgery is just a planned tissue assault and injury is just an unplanned one, essentially. So early stages, it may be we're looking for lower dose, higher frequency. So when I talk about dose, it may be the external load applied. And then as we get a little bit more general, they're returning to their normal activities and we're heading into maintenance mode. It becomes quite general with, okay, you may be able to do 30 minutes today, tomorrow you might be able to do an hour, and then they've just built that familiarization and the knowledge about when they're pushing too far, when they maybe not be pushing hard enough. And then again, if we're heading into performance mode, that's when we again become a little bit more prescriptive with, it's this number of sets, it's this number of repetitions, it's this amount of external applied load with this rest break and this frequency. So AMRAP, it's very applicable in the early stages. Now, why it's so beneficial is everyone comes into a clinical setting, or before they have an injury, everyone has their own very individual baseline level of fitness and function. So someone, they might be an older person who they're quite sedentary, then they sprain their ankle. Their baseline level of fitness and function is going to be quite different to an 18-year-old who's played netball for 10 years and they have a higher level of agility and base strength and bone mineral density. Their baseline level of fitness is going to be vastly different. But they both have this injury that will have a slightly different level of reactivity depending on the severity of it, other systemic factors. So when we use AMRAP, this is how we can help patients engage in that, again, the higher frequency, lower dose movement, which is very important in the early stages of tissue healing. And not just early stages of tissue healing, early stages is if we're trying to overcome, say, some sensitization or mechanosensitivity. because we want to decrease that threat response. So if the body is repeatedly exposed to a non-threatening or a very low threatening movement over and over, then that's how we dissipate that threat. So then there's less panic, then we can push the bar a little bit further and introduce slightly more complex and higher load movements. So when let's say we're dealing with post-acute injury or post-surgery, so it might be in the very early stages of rehabilitation where we've passed the inflammatory phase, which is the first few days, and then we're heading into sort of granulation and that subacute phase. And this is where a lot of that tissue healing occurs. And this is where oftentimes it's very important to introduce those low-grade levels of load in a higher frequency so we can help facilitate especially the collagen remodeling. So very important, muscles, tendons, ligaments, and then bones a little bit different, but that's getting into another realm. Let's just say we're talking about soft tissue. Muscles, tendons, ligaments. Very much ligaments and tendons. Again, depending on the severity. So we always need to respect tissue healing timeframes, but again, too much for today. We're talking about dosage. Okay, so AMRAP for time, where this fits into the equation is we've got our parameter for time. So it's, okay, you may be performing this one specific movement and we're setting the end parameter for 30 seconds or 60 seconds. Now I want you to perform as many slow controlled movements in that 30 to 60 seconds as possible. Now where we couple this with education to help them understand how many repetitions they should be doing and when they're ready for the next dose, it works really well with the traffic light system. So this is pinched from a lot of the tendinopathy rehabilitation works that are out there, and we do have a couple of podcasts and blogs on this as well. But essentially we use the VASP, Visual Analog Scale of Pain, 0 to 10. 0, no discomfort, 10, worst discomfort imaginable. And then, so green is green traffic light, 0 to 3-ish. Orange or amber is sort of 5 to 6 or 5 to 7, and then 7 or 8 plus, that's our red zone. So we don't want to head into that because that's typically when we're overdosing and we're asking for trouble. So when we think about this, why it becomes, it shows its clinical utility is, like I was mentioning earlier, everyone's baseline level of function is a little bit different and everyone's level of reactivity is going to differ as well. So we've got age, all of our extrinsic factors as well coupled in with this. So we may find that if we're giving someone 3 sets of 20 repetitions, it may significantly overdose someone, and then they may only be able to do that lot of exercise once, and then they need 6 days to recover from it. But then we may have someone else who that 3 lots of 20, it's not even touching the sides as far as reaching a level of stress that will create a positive tissue adaptation. So by giving them the AMRAP for time, coupled with that information as far as this is an acceptable or don't panic level of discomfort when you're performing the movement, this is where there's a little bit of caution or guidance. This is how we can help really reduce the likelihood that someone's going to overdose some rehab. And it also helps improve people's understanding and decrease that threat perception, because some people, after they've had surgery or an injury, any form of discomfort is a threat and, oh my God, I'm going to make this worse. But no, a lot of the times that's not the case. The body will just be somewhat grumbly because we're mechanosensitive, because we've had an injury. So it's helping them understand that, no, this is an acceptable level of pain. You can still function. You don't need to wrap that area in bubble wrap and not do anything for 2 weeks. Because as we know, if we do that, we actually move the recovery goalpost further away. So I'll use the example of, let's say we've got someone who they've had their HAV correction surgery. So we may be seeing them 2 to 4 weeks post-operatively, and they're ready to start some really gentle range of movement exercises for the first MTPJ. So what I may do with people is, instead of saying, okay, you're going to do 3 sets of 20, because again, it might overdose someone, is I'll do we're aiming for, again, high frequency, low dose. So it might be, okay, for 30 seconds, you are going to perform really gentle flexion and extension. give them some parameters as far as this is the range of movement we're working towards, this is where you need to hold it, so it's just the technical elements. But for 30 seconds, you're just going to be performing as many slow controlled movements within that time. If you find that the numbers are creeping up, so you started at a baseline of 0, so there was no discomfort, then you started doing the movements, and then maybe sort of 5 to 6 repetitions in, which might be, I don't know, 13 seconds, it feels a little achy and you just need to rest it, or you're getting a bit crampy, that's fine. Okay, so you've stopped, you've rested for 5 or 6 seconds, it feels like it's eased up and you're good to go. So there might be another 10 seconds left on the clock, just keep going. So, and then once you hit the 30 seconds, you're done until the next load exposure. Now, what will determine the next load exposure, like I've covered very much in the free CPD webinar that we've got, the How to Navigate Rehab in the Presence of Pain, which you can access via P3 for free. Just head to the website, head to the free CPD section. But what may sort of indicate the next, well, when they're ready for the next load exposure is that resetting back to baseline. So they may do their movements, and then in theory, we've got it planned for in an hour or 2 hours time. That's when you'll do the next lot of 30 or 60 seconds. But they may find they go to do it and, oh, it's still sort of sitting at a 3 out of 10 from the last time. Okay, just give it that little bit more time. So it may not be 1 to 2 hours, it may be 4 hours. Okay, it's settled back down, now we're ready to go again. So this is having them aware of their body and just getting used to the sort of ebb and flow of discomfort in response to load, but then also not pushing too hard and actually adding too much load, so we're heading into a reactive flare, if that makes sense. Now, there's a couple of other instances where the clinical utility of using AMRAP for time becomes very useful. And we need to remember that not every patient has ever done any prescribed exercises. So whether or not it's in a gym setting or it's in a rehabilitation setting, whatever it is, some people's levels of health literacy and movement literacy can be very, very low. And if we think about when we have a musculoskeletal injury, it's a stressful event in itself. It's disruptive to our life to varying degrees, depending on the severity of the injury, the body part that's injured. But then we also have coming to an appointment is disruptive in itself. So they're having to make time out of their day. They have to get to the clinic. It's costing them money in a lot of instances. So there's all of these other elements going on. We may be giving them a huge amount of information as far as what's happening with their injury, what the prognosis is. They're stressed, they're focused on this, and then they're focused on, oh, I've got to get the kids in 20 minutes, and oh my God. So a lot of things going on. Now, some people, adding in the prescriptive elements of, okay, I've got to do this exercise, which I've never done before, even though you've given me a link to a video or you've given me this printout, and God, please don't do stick figures. Hopefully we're beyond that. But you've given them the information, and that may be a little bit overwhelming itself. And then they're like, oh, I've got to do sets and reps. Now, is the sets, how many I do in one hit? So some people, they just can't wrap their head around that. Most people can wrap their head around time, hopefully. Some people can't, but most can. So if you have someone that it seems like a little bit of a cognitive overload with the prescription of sets and repetitions, sometimes going to the AMRAP for time. So in the clinic, if there's someone where it's not so much a tissue reactivity that you're trying to navigate and you've given that sort of 30 to 60 second window, it may be more just the stress of doing sets and reps. What you can do is if they're in the clinic and you're getting them, let's just say it's a calf raise or whatever it is, you can just time how long it takes them to perform that number of repetitions that you're roughly aiming for, and then, okay, well, that's just giving you a parameter for how long they may need to do it. So 45 seconds or 30 seconds, however long it is. And then again, couple that with the traffic light system. So that's just how I use AMRAP for time to encourage more regular movement exposure, so that high frequency, low dose, because again, like I've mentioned a few times already, it's especially when we're in the early stages of tissue healing, it is the higher frequency, lower dose that we need for that connective tissue remodeling. And also if we're dealing with some of that mechanosensitivity to help dampen down the response, but then giving them the parameters of, overdosing and underdosing, so paying attention to the levels of discomfort. So it can, in summary, basically help us navigate it if we're not too sure about what the appropriate number of sets and repetitions are. So that's one. Again, couple it with the traffic light system. It can help our patients improve their level of self-efficacy as far as self-dosage and just having an understanding and building a better relationship between their body, their injury or post-surgery, and discomfort. So it can help them understand discomfort a bit better, knowing when I can push, when I need to pull it back a little bit. And then also if they just have that little bit of stress when it comes to more prescribed dosages of movement. So hopefully that gives a little bit of a pretty short, sharp summary of how we can use AMRAP for time. Now, just circling back around to kind of wrap it up and how I deliver this to patients. So let's say we'll use that example of first MTPJ rehab in post-operative HAV. Okay, so it might be, again, 2 to 4 weeks post-operatively, introducing the exercise. So what I would have done by this stage is explain the role of exercise and rehabilitation. So as far as the tissue healing and the connectivity, building capacity, all of those nice things that we like to talk about. So we'll be talking about that. And then linking those tissue responses to what we're actually doing. So you're getting this movement because the surgery they did, and the connective tissue is needing to heal. So if we introduce some movement and it's that high frequency, low dose movement, it just helps the connective tissue heal the way that we want it to heal, which actually helps you recover faster. And again, this is where you start to link in your therapeutic goals and therapeutic intervention to their client goals. So you recover faster, you get back to walking the dogs around the block a bit faster. And then we're going into the overdosing and underdosing. So in a rehab sense, more isn't more. Like sometimes more can be too much and it's not great. You can overdose. So we're going to go with the time. So 5 to 6 times a day. I'm just picking arbitrary numbers, so don't follow this. It varies from person to person. So 5 or 6 times a day, you're going to be doing this movement. So gentle flexion, extension. I've explained the range of movement and that we're after quality, not quantity, because a lot of people, they think, again, more is more. So in that 30 seconds, I may be wanting to do 40 repetitions, but what they may do is shortchange the range of movement and they may move too fast and flare things up. So I'll tell them quality over quantity. So I would rather you do 15 slow controlled movements in that 30 seconds as opposed to trying to knock out 30. And then we've given them the traffic light system. So 30 seconds is on the clock. You just start your slow tempo. You may find that you get to 15 seconds and it gets a little bit achy or you're a bit crampy or uncomfortable. And okay, so just rest, shake it out. You may find it takes 5 or 6 seconds for it to alleviate. Okay, great. You've still got 12. I don't know if I'm up to 30 or not, but you may have 10 seconds left on the clock, but you feel ready to go again. Okay, just pick up where you left off. So it doesn't matter in that 30 seconds if you can do 10 or if you can do 20. It's just the fact that you're doing it and you're doing it regularly and not pushing too hard. So that's usually how I'll explain it. So hopefully that gives you a nice little wrap up of how we can use AMRAP for time in a couple of different clinical situations or circumstances. Now, if you would like a free rehab resource, I've got the Movement Prescription Blueprint, which is essentially a rehab guide that I've designed to help step you through the rehab thought process. So identifying client goals, your therapeutic goals, dosage parameters, and so on. So if you would like this free resource, head to progressivepodiatryproject.com/blueprint, and looking forward to the next couple of episodes. We've got some great ones coming up and I'll catch you then. Cheers.